office on the committee, and we just wanted to say on behalf of our office, thank you and welcome. It's really exciting to see a full house with so many people here to learn about this important issue. As I hope you know, this is something that Senator Harkin has long been interested in, so I want to thank you all for coming and to educate us on this important issue. Thank you.
So good morning, everyone. I'm Janine Kogan. I'm the Policy Director of the Eating Disorders Coalition. And I'll start our briefing today by thanking Senator Harkin for supporting this briefing. And actually, he's been a champion working with us to address eating disorders for years now. And it started long before he introduced the F.E.A.S.T Act. He's the lead of our signature bill. He helped us get some report language into the bill to address this very issue, actually, where we were trying to get CDC to be able to give us some good mortality data related to eating disorders. So he's been a big champion, and we're really grateful that we have him in our corner. So thank you so much to Senator Harkin. So today we're addressing 10% is unacceptable. So that really is the mortality rate associated with eating disorders, and eating disorders have the highest mortality rate of any psychiatric disability. When we think of someone having a mental illness, we tend to not think they're going to die from it. But with eating disorders, unfortunately, that is a reality that we're faced with. So we are doing this briefing, the Eating Disorders Coalition, in conjunction with F.E.A.S.T. And so we're very grateful to be doing that partnership. I'm going to just list or read to you who our speakers are, and they're going to be in this order. And then they're just going to each individually come up. I won't reintroduce you. So thank you so much, panel, for being here today and sharing your wisdom and experience with us. So our first speaker is going to be Dr. Mark Chavez from the National Institute of Mental Health. And the title of his talk is What the Research Shows, Mortality Statistics for Eating Disorders. Next, we have Amy Snyder, who's a mother, and her talk is titled, Who Are We Fighting For? People Like My 7-Year-Old Daughter. Next, we have Julie O'Toole, Dr. Julie O'Toole. She's the founder and medical director of Cartini Clinic, and her talk is Saving Lives with Early Intervention, a Pediatrician's Perspective. Then we have Joan and Justin Ryder, and it's a mother and a brother, and they are going to be talking, their title of their talk is Giving a Voice to My Family's Years of Support, Hard Work, and Tragic Loss of Aaron. Then we have Laura Collins, who is the policy director, or still the executive director, soon to be policy director of F.E.A.S.T. And her talk is entitled The Central Role of Families. And then I'll come up at the end and wrap it up with how Congress can address this issue. So let's begin with our first speaker, Dr. Mark Chavez.
So first, on behalf of NIMH, I'm really happy to be able to participate in this morning's meeting, and I thank those groups who invited me to do so. So what I was specifically asked to do was talk about data regarding mortality rates associated with eating disorders. And that is an important that I will do. And the data that I talk about, if anybody's interested in where these numbers came from, one of the things that you can do is you can just send me an email. You just Google NIMH Mark Chavez, you'll get my contact information. And I'm more than happy to send you any of the references for any of this data or any of the points you may have. If I would have those references, I'd be more than happy to forward this data. Okay, so what I was had to talk about was talking about mortality, but I think there's one point I'd like to make before I get into those specific numbers. I don't have a lot of time, and I'm not going to take a lot of time. And I think probably I'm going to have to tell this to all of you, and I don't think this is something that we really think that much about at NIMH, and that is, let's put aside the mortality data just for 1 second. But if we do that, even independent of that mortality data, the eating disorders are incredibly serious and debilitating disorders. I mean, the impact of the psychological impact, the financial impact, the visibility associated with these, not only how it affects the patient, but how it affects the family. I think these problems are immense. And so I think the mortality data, one of the things it does, it really brings home some of the severity, some of the seriousness associated with disorders. But in and of themselves, even independently, these are very, very, very pernicious disorders. And for somebody not to be aware of that or to trivialize it in any way, I think is ignorance. Okay, and I think one of the other things, as you said, with most psychiatric disorders, you're not necessarily thinking about mortality. I mean, a lot of them have, there is suicide associated with them, a lot of comorbidities, things like this. But I think with the eating disorders, there really is a very, very high rate of both psychiatric and medical comorbidities. And I think these are a lot of times responsible for some of the mortality that is actually seen with these disorders. But these, some of the effects they have on electrolytic balance, cardiovascular function, renal function, osteoporosis and bone growth, suppression, immunosuppression, and impairments of the immune system. I mean, some of the other high levels of clinical depression, substance abuse. So these disorders, very bad in themselves, but when you combine them with some of the medical and psychiatric comorbidities, these are very, very serious, very, very dangerous disorders. Now, NIMH, when we talk about the eating disorders, typically what the discussions revolve around are what is the research that we really need to see being done in order to give us a better understanding of the etiology, what's causing these things, what puts a person at a higher risk, understanding some of the pathophysiology, what mechanisms the central nervous system as well as endocrine systems are really responsible for not only some of the etiology, but also the maintenance of these disorders. There are some treatments for eating disorders. I think we do have reasonably good treatments. Other areas, I think they're very much lacking. And I think there's no question that we'd like to see an improvement in what we have. Not only an improvement in the treatments we have, but when we actually disseminate them and making sure that they're actually being implemented the way they're intended to be implemented. That's the only way they're really going to be effective. Are there prevention programs that can be done, that can be established? And research-based prevention programs will actually help, hopefully, prevent a person from converting to a full-blown eating disorder and catch something early. These are the discussions that we have at NIMH. So we look at the portfolio, we see a lot of areas where we really do need research. But we never talk about, is this serious? Is this a boutique question? Is this a boutique problem? Is this really something that doesn't necessarily have to have the priority as it needs to? We don't have that discussion because I think the data all is there to say absolutely. There's actually no question about that. And I find it surprising when I talk to a lot of the advocates, because again, I deal in the scientific world, and I think the people I deal with, they also understand these disorders. But when I talk to the advocates, and I think a lot of what you're dealing with out there when you're trying to get a child treated and some of the responses, some of the treatments, it's very good for people like me to actually hear this, because again, some of these ignorance, just based on the experiences you've had, I find it appalling. It's very offensive and it's unexcusable. So having said that, my time's about wrapped up. So what I'm going to do is I'm going to talk about the mortality data associated with this disorder. And typically when you talk about mortality data, the way that this is generated, we look at standard mortality ratios. And so what you do is you get a very specific, say, patient population, for example, anorexia nervosa. You pick a time framework that you can read, the data that's going to be analyzed. And what you do is you get that standard population, and then you also get the standard population as a comparison. And that standard population gets matched on demographic variables like age, sex, those type of things, looking at them within the same time frame. And they compare that ratio to each other. How many expected deaths would you see in the standard population? How many do you actually see in the English population? That's how mortality is calculated from a medical perspective. And any time that number, that ratio is greater than 1, that means that in the study population, for example, anorexia nervosa, there's excess death in the population relative to the general population. Again, we've been matching all kinds of demographic variables, main differences, standard population has never had or never currently had, and these are 25 deaths. Okay, so the standard mortality ratio for anorexia nervosa is based on a very current, very large meta-analysis. It collected, the studies that were done in Europe as well as North America. A very well-done, very rigorous study. The standard mortality ratio for anorexia nervosa is 5.7. So there's a 5.7% greater chance of dying if you have or have had a diagnosis of anorexia nervosa relative to the general population. That's not a trivial number. And I think the data for bulimia nervosa is 1.93, and the data for binge eating disorder is 1.92. There's a lot of eating disorders not otherwise specified categories. The data is not good for that. I'm not comfortable talking about that because there's some numbers, but I think there's just problems with it. It makes it very difficult to really give a number that I would actually feel confident with. One thing that I was happy to see is that the budget, the 10%. I did try to find numbers. I found what I thought was best studies to generate this number. But these numbers, when you look at them, just these three categories, it really does. It's about 10%. It's 9.7, 9.6. So that's actually very nice to see. There is a clear correspondence between the two. The last point I want to make, and I think part of the reason I want to make this is when I saw these numbers for the first time, they shocked me. And so, again, looking at standard mortality ratios, at this time, instead of looking at general mortality, we're going to look at suicide. So standard mortality, mortality due to suicide. So you do the same thing. You have a study population, you have a general population, maximum on age, sex, and many of these demographic characteristics possible. And again, you look at the ratio. Again, any time the number is greater than 1, there's excess death due to suicide in the study population. So the standard mortality ratio for anorexia nervosa is 31. So your chances of dying from suicide, if you have been diagnosed with anorexia, if you currently deal with anorexia nervosa or had a diagnosis, is 31 times greater relative to the general population. I mean, that's, it's say this isn't a serious disorder. I mean, it's just absurd. The other, if you look at bulimia nervosa, and again, I have data, but I actually am confident talking about the bulimia nervosa with the other category. I don't think the data is really there, but it's 7.5 for bulimia nervosa. Again, it's a very, very high number. So, again, I want to thank everybody. And again, any of these references, if you want to see these numbers came from, how these numbers are generated, contact me and I can send you, those references. Okay, and I think that's really all I have. So again, thank you very much for inviting me.
Hello, I'm Amy Snyder, and I'm really glad to speak with you today. I see a couple people standing, and there are chairs available. I don't know if you'd like to sit. There's chairs up here, and there's a floor over there. Although so I'm here as the mother of a daughter who's 7 years old, and my 7-year-old daughter, Olivia, has anorexia nervosa. Olivia decided to eat healthy, and I didn't know, she didn't tell me about this, but I noticed that she was eating fewer sweets, and in January she had a birthday party, and I noticed she just had one bite of the birthday cake. I didn't know that she was hungry, but that she was powerless to eat. We had no idea. She did have some physical problems, though, that I took her to the pediatrician for. She was itchy, and she was dizzy, and she had digestive problems, constipation. So I took her to the pediatrician a few times for these issues after January this year. And for itchiness, the pediatrician suggested Vaseline. And for constipation, she suggested a fiber supplement. And for dizziness, she suggested that my daughter not get up so fast. Needless to say, she didn't connect the dots. On May 7th, I was tucking my daughter into bed, and she whispered to me, "Mommy, I have a problem." And I said, "What's your problem?" And she said, "I'm hungry all the time, but I can't eat." "Why can't you eat?" "Because I have a mean voice in my head that tells me not to eat." And she said, "Because I'm afraid I'll get fat." So I got her out of bed, I gave her a snack, and I put her back to bed again. And that night I went on the internet, and I began to do some research. And I was horrified to learn the reality of anorexia nervosa, the mortality rate. At the same time, I found some hope in a method called family-based treatment. It's also called Mosley method, that emphasizes that nutrition comes first, that we first have to raise the weight of the sufferer, and that would give hope to get rid of this mean voice and to help her recover psychologically. I learned then that recovery was possible. I also learned that my daughter was really lucky because I caught this early, and that this meant she had the best prognosis. Most kids' anorexia isn't caught early. Many children are ill for years. And why aren't they caught early? Well, just like my daughter's pediatrician, that pediatricians don't know how to connect the dots and figure out who has this illness. So a question to ask is, how do we keep our children from dying of this disease? Well, we need physicians that are up to date and that don't take a wait-and-see approach. Parents need skills to feed their children. It's not easy to feed a person who has anorexia nervosa because essentially the child is afraid to eat. They're afraid of food. But there are skills that we can learn that make it possible to feed our children and to require eating. We need insurance to cover evidence-based treatment because insurance doesn't necessarily cover the kinds of things that you need. To keep our children from dying, everyone needs to know not to wait, that kids do not choose to be ill with this disease. That disease is not about the child trying to control their environment or a child trying to control their family. Anorexia nervosa is like obsessive-compulsive disorder in my daughter. My daughter has a mean voice in her head that tells her not to eat. She's had this mean voice, I've learned recently, as far back as preschool. She remembers mean voice telling her to do and not to do certain things. But mean voice wasn't always interested in what she ate. That came later. Everybody needs to know about magic plate, which is a technique for refeeding, and it worked well for my daughter. To keep our children from dying, families need support. We have lost income from taking time off work. We went without income for 3 months this summer because we needed 2 parents both to feed our daughter and then at the same time to take care of our son who has autism. We need insurance reimbursement for in-home caregivers because people with anorexia may need supervision. Like my daughter will eat if someone's watching. She came home from school one day with a full lunchbox, and I saw, when she saw me pick up her lunchbox, her eyes filled with tears, and she said, "I couldn't eat, Mommy, because nobody was watching." Because the person who was supposed to watch her at school wasn't there that day. I would love to see every medical practice have at least one physician on their staff that knows what they're doing, is up to date, and can properly treat anorexia nervosa. It doesn't have to be every single physician, but that everybody in the practice knows, okay, you need to see this person instead of me, and they'll get you squared away and on your way to recovery. So how is my daughter doing today? Well, she is what's called weight restored. I mean, her weight is great. She's got what she needs and more, and she's growing taller. She wasn't growing for a while. Her mean voice is weaker. With her weight being at an appropriate place, her compulsive exercise is way, way down and even disappeared in the last week. This is common. Compulsive exercise is common in starvation, but with the proper weight, it loosens its grip. Olivia said to me, "Mommy, now that I'm eating, I can understand what I read." She's like, "Now that I'm eating, math is easier." She now says math is her favorite subject. Now that she's eating, she can have life. So how do we keep our children from dying? Well, food is the medicine that fights anorexia nervosa. And if we all work together, we can prevent needless suffering and death. Thank you.
Well, my name is Julia O'Toole. I'm a pediatrician. I am the founder of Cartini Clinic, which is a pediatric eating disorder clinic. We see children with all conditions of disordered eating. In childhood, that means somewhere around 80% will have anorexia nervosa. Over the years, we've seen, as I said, greater than 2,000 children. I'm not a member of an academic institution, except peripherally, nor of the NIMH, nor of the NIH. I'm a pediatrician slugging it out in the trenches. And I would like to talk to you about the prevention of unnecessary death in children and in young adults from eating disorders. I'd also like to talk today about those children who don't die, but whose lives and whose growth is stunted by chronic malnutrition and semi-starvation, and the effects of that on the brain. We should put it right out front. Anorexia nervosa is a brain disorder. It is a chronic mental illness. It is highly heritable. Parents do not cause it. In fact, they could not cause it. And children do not choose to have it. So let's talk about the effects of starvation on the brain for a second. It is true that most of our brain cells are formed before birth. However, the connections between the brain cells, which is what affects functioning, are being made throughout childhood and early adulthood. When you can't focus and concentrate, you can't learn. Anything that adversely affects learning impoverishes and trims the connections between the cells in the brain. The inability to focus and concentrate that you mentioned is almost universally reported to us by our patients and by our observant parents. It's a direct result of food restriction. And we're not just talking about the kind of learning that takes place in school. The limbic system, a central part of the brain, known to be affected by anorexia nervosa, for example, controls emotions, attachment, and memory. Core features affecting what a child will be like as they grow up, and importantly, what happens to them later. A child's frontal lobes are the last to become connected. Major functions of the frontal lobe are judgment, insight, and impulse control. Behavioral attributes whose underdevelopment can lead directly to depression, despair, and the eventual suicide reported in half of the 10% who go on to die of their illness. Happiness, hopefulness, and resiliency are necessary human traits in the quest to prevent a young person from becoming overwhelmed by despair. And I think those of you who've ever seen anorexia nervosa as only one eating disorder, bulimia nervosa, understand the depth of shame, despondency, and despair that these illnesses cause. In the past, pediatricians have assumed that only starvation during infancy profoundly affects the brain. However, more recent work on famine really shows that malnutrition throughout childhood can affect brain development. Some of the studies have even challenged the notion that the impact of starvation on the brain is entirely reversible. The specter of irreversible damage to the brain of a child is one of the serious reasons why we have got to get serious about treatment and prevention of anorexia nervosa. Which brings me to my second point, loosely called prevention, but actually called secondary prevention. We don't know what actually causes eating disorders. The biology of these brain disorders is very poorly elucidated. Whenever that is the case, primary prevention is not possible. For example, we couldn't prevent tuberculosis until we understood that it was an infectious disease. We are literally at that stage in understanding the biology of eating disorders. This leaves us with what is called secondary prevention, otherwise known as early recognition and intervention. That's what we're here to talk about. It's clear from our clinical experience and that of other eating disorder physicians who see children that even children as young as 6 years of age can develop eating disorders and begin to starve, typically slowly at first, with simple food refusals, and more intensely later with weight loss. When a child this young, somewhere between the ages of 6 and 12, has their brain growth stunted along with their physical growth, and this goes unrecognized, we may never be able to completely restore them to health. So weight loss is a critical clinical sign and symptom that goes under-recognized by pediatricians across this country and indeed across the world. Educating pediatricians, nurse practitioners, family doctors to recognize the symptoms of early onset eating disorders and to take them seriously is critical to secondary prevention. Educating the general public to the newer scientific findings that these illnesses are life-threatening brain disorders and are not caused by parents or by misguided ideals of thinness portrayed in the media, seductive though that concept may be, is going to be essential to moving forward with secondary prevention. Once the genetics and neurochemistry is better defined, and we understand the mechanics of how this can happen to the brain of a child, we can talk about primary prevention, but not until then. Until then, we need to focus like a laser on early recognition to prevent disability and death. And to this end, teaching parents as the best observers of their own children and utilizing parents as a sort of early warning system for pediatricians. Teaching pediatricians not to brush off the concerns of parents is going to be critical. It sounds simple, but it needs a concerted educational effort, and in this quest we ask your help.
I'm going to be the lead child here, and I need to sit down and talk. So bear with me. I hope you can hear me. Tell me if I need to be louder. A little closer. Okay. Good morning, and thank you for the opportunity to be a part of this congressional briefing. My name is Joan Reeder, and I'm from Elm Grove, Wisconsin. I'm the mother of a young woman who was diagnosed with anorexia nervosa at age 11. Sadly, our daughter Erin lost her life in June of 2010 after 17 years of battling this malignant disease. From the very beginning, our family realized that there was no straight course to recovery. This disease required involvement of the entire family, and it was up to us to find caregivers knowledgeable in eating disorders. Thus began my involvement with the National Eating Disorder Association. Each year I would attend the conference, searching for information, talking with those I was told were the best in the field, afraid that I would miss a presentation that held a clue to our daughter's recovery. I gradually became more involved as a member of NEDA committees, joined the Eating Disorder Coalition, participated in lobby days, and became a charter member of the Eating Disorders Dream Bill of 2007. Shortly thereafter, I joined the Academy of Eating Disorders and was appointed to the International Committee of the Worldwide Charter for Action on Eating Disorders. In 2007, I was one of the first parents that was invited to speak to the AED membership. On that day, I implored the field to address the death issue from anorexia and eating disorders. It's now 5 years later. Our daughter is now autistic, and we are no closer to finding the key to the treatment of eating disorders. How many generations of families will lose their loved ones to this awful illness? The years passed quickly. Before we knew it, Erin reached the chronological age of adulthood. This is when the nightmares truly begin for the parent of an anorexic child. The most important element of their recovery, their family, is the enemy. Legally, parents are not allowed information regarding their loved one. Anorexia loves this, as the very nature of the disease is to protect the anorexic self. Our daughter exercised her legal rights to maintain her eating disorder. There was no legal assistance or support to help us as a family. Despite continued treatment at numerous treatment facilities across the country, Erin's illness would not abate. We found it necessary to obtain legal guardianship of Erin, eventually having guardianship in 2 states. Another legal and a financial nightmare. The laws regarding legal guardianship vary from state to state. Many patients are treated out of state, requiring coordination of these guardianships. On one occasion, Erin was admitted into treatment as our own state guardianship was expiring. Within days, this psychiatric hospital enacted a Chapter 51 state guardianship of our daughter. Erin was admitted to a hospital for medical stabilization and frantically phoned us to tell us she was being transferred to a hospital with a general psych unit having no eating disorder expertise. I arrived at the hospital to advocate that Erin be sent to a specialized eating disorder facility. I was told I would be arrested if I obstructed this decision made by the state. After a 6-week stay at this facility, she was discharged at an unacceptably low weight and no follow-up care. In my opinion, a state guardianship is a death sentence. Another mother from our state described how her daughter was transported to a state-run facility in handcuffs with prisoners. Also, we learned that many major hospitals will not admit eating disorder patients with guardianships without the patient's written consent. Is this not the reason a parent would obtain? This is true, folks. Major institutions. In addition, now these young women are labeled as treatment resistant and chronic. The financial toll on our family also needs mention. Early on in our daughter's treatment, we found it necessary to challenge our insurance company after they denied residential treatment. It was necessary to remortgage our house, as waiting to start treatment was not an option. After a very lengthy battle, we were successful in obtaining full coverage. Unfortunately, all the insurance in the world did not make a difference in the outcome for our daughter. Erin's treatment history was lengthy: admission to inpatient or residential treatment for months with weight gain, discharge, and relapse again. Along the way in our daughter's treatment, there were numerous setbacks in her care. Well-meaning caregivers who unfortunately were not educated in the medical care of malnutrition and refeeding were not uncommon. An emergency room physician continued to administer IV fluids while not monitoring Erin's albumin blood levels, resulting in severe pitting edema in both legs. She required hospitalization for 6 weeks to resolve this problem, during which she had a heart-related incident. Luckily, Erin survived this. These events could have been avoided with proper care. In the final month of her life, improper follow-up care resulted in her ultimate demise. A primary care physician failed to order stat lab tests, combined with a hospital that had no policy for returning lab results in a timely manner. Our daughter died alone in her apartment at age 28. Over the many years of searching for quality treatment and reading every piece of research we could find, we have learned that without an extensive increase in research dollars, there will be no cure for this disease. Without increased dollars for education of caregivers, we will continue to have eating disorder patients fall through the cracks, resulting in an ever-increasing death rate. It is our opinion that an increased response of our federal government is necessary to enforce regulation of Article 4 of the United States Constitution. Article 4 is the full faith and credit clause. This article states that the full faith and credit shall be given in each state to the public acts, recordings, and judicial proceedings of every other state. This would allow families to act as guardians of their loved ones and access immediate care regardless of the location of treatment providers. 10% is not acceptable.
Hello, my name is Justin Reeder. I'm the little brother of Erin. I'm currently a senior at the University of Wisconsin-Madison. I'm studying neurobiology, and after I graduated in May, I planned to attend medical school. My sister was always in the business of making those she loved happy. For me, it's part of her personality was summed up as me and my parents traveled to Boulder, Colorado to clean out her apartment after her passing in June 2010. There in her closet, I found an already wrapped present with a card on top that read, "Thanks for coming to visit me, little brother." I was supposed to visit my sister in Colorado just weeks before her passing, but unfortunately she had to cancel because she was too ill. Growing up as the little brother bear, I saw my sister so thin, it was a miracle she could stand. I saw her in too many hospital beds to count. I saw her with feeding tubes in her stomach as we opened presents around the Christmas tree. I saw her in tears so many times, more times than I wish to remember, from the eating disorder that was destroying her life. Through much of this, I felt like a helpless observer, my big sister's life shattering before my eyes, and me having no control over what will happen next. Even before her passing in 2010, anorexia nervosa took my sister away from me. As I got older, seeing her more than once a year was rare. She was always in treatment. I couldn't just visit her whenever I wanted to. While in high school, the longest I got to see her was a few months stretch while she was treated in a local hospital. My only chances to see my sister were when treatment brought her close. I also saw anorexia nervosa straining the relationships between everyone in our family. Countless arguments between my parents and sister about the most minute smallest amounts of food. Arguments between my parents over how to pay for all the treatment my sister needed. Growing up, dinner table conversations like, is insurance going to cover her treatment, the legality of my parents' guardianship, and have you eaten today were the norm. I felt like I was always caught in the crossfire, not wanting to say anything that would upset my parents or my sister. Of course, my memories of Erin are not all bad. I can always picture a photograph that hangs in the kitchen cupboard of our house in Wisconsin. There she's hanging upside down on a pair of monkey bars. It sums up everything that my sister could have been had she not been defeated by this disease. It captures her intelligence, her goofy sense of humor, and how much she could love life. I've now come to the point where I can think of my sister and remember all these qualities that made Erin my big sister. These are the things I want to remember. Not my dad stopping me in the den of our home and telling me that my sister has passed away from this illness.
My name is Laura Collins, and I'm Executive Director of F.E.A.S.T, and we are an international organization of parents of caregivers. And it is a tremendous honor to have this opportunity to have you hear from these families and to hear how very dangerous and grueling this illness is and how it affects families. I'm really very honored to do this with the Eating Disorders Coalition because I believe that the only way we're going to make progress with this disorder is for all of us to stand together, for families to stand up as we have never done. We have been ashamed and we have stood back and we have been embarrassed and at times felt guilty unnecessarily. And so being able to have this opportunity to do this with all of you, it feels to me like we're entering another era where we are all together and we make some progress. Because 10%, this number, has something that we just keep talking about as if there's no way to change it, and I don't believe it. Let me tell you why. Eating disorders are not just about eating, and that's often what we keep saying, that it's about eating, but it's a mental illness, it's a brain disorder, it's incredibly serious. There's nothing about it that has to do with vanity or bad parenting, and we need to stand together with the science on this and understand it's not just about eating. As we've established, eating disorders kill people. They also destroy lives and destroy families. We know that patients do not choose to become ill, and I think the analogy to OCD is far more accurate to the science. Families do not cause eating disorders, and I'm sorry that I even have to say that, because it should be assumed now, as it is now with other mental disorders. We need to just stop saying it, and very soon I hope to stop having to repeat it as a denial, because we won't just start with that assumption anymore. We also need to know that treatment works. I think there is a defeatism out there that makes people think, well, this is a horrible illness, how awful, people are dying. But we're not talking about the fact that good treatment does work, and families will stick with it, and stick with their loved one through thick and thin, can be successful. Not always, but this 10% statistic is something that we've gotten stuck in, and we need to stop accepting it. Eating disorders can be successfully treated, families can be involved, but we are not doing it. The science is not making it out to the people. Although I appreciate that for researchers, it's just a given, and that for certain pediatricians, we're on board. And a lot of us families are on board, but the fact is, getting adequate treatment that brings you through from diagnosis to intervention to remission and keeps going to prevent relapse is not happening because of real things that we can change. And that's one of the reasons we're going to be talking about the F.E.A.S.T Act. So my organization and over 2,000 families around the world and clinicians want to make this the date when we stop saying that 10% is the mortality rate for eating disorders. It's only that rate because we've allowed it to be. And we're going to change. And we're going to stand together and we're going to do it. The board of directors of my organization, our advisory panel, and our members are calling for us to make a worldwide declaration that we find the 10% statistic unacceptable from this day forward. We have to make recovery the rule and the loss of life as a rare and tragic exception. This has to be the last generation, and I really believe we can do this, where a family goes on the internet or goes into a doctor's office and hears that their precious child has a 1 in 10 chance of dying. We don't have to do that. So now I would like to hear about the F.E.A.S.T Act, which is something that we all can do.
Offer another story as context and then tie in the F.E.A.S.T Act. So I want to continue a theme that has come up through a number of people's talks, and that is what happens with the stigma and misunderstanding that we are currently up against with eating disorders. So let's imagine a 19-year-old comes to an emergency room, breathless, in excruciating pain, clutching the side of her stomach. She's pale and weak, doubled over in discomfort. The doctor on duty does a cursory exam, asks the patient a few questions while checking her vital signs, and determines you're having an appendicitis attack. The doctor immediately schedules surgery. The infected appendix is removed, and the patient recovers and heals and returns to her college classes and resumes her daily life. But what if the doctor decided not to treat this patient? Can you imagine that? A person with a ruptured appendix who's doubled over in agonizing pain, not being treated, and she dies. Not because the doctor misdiagnosed her, she dies because the doctor refused treatment. That's exactly what happened to Leslie George. Leslie, a 19-year-old student at James Madison University, right around the corner, just a few hours away here in Virginia. She was in unbearable stomach pain after a severe eating binge. She said she felt like her stomach would burst. At the emergency room, while on the exam table, Leslie told the doctor, "I'm bulimic," and that she had eaten a huge amount of food. The doctor stopped. He refused to pump her stomach once he learned the reason for her pain. The doctor walked away from his patient. Because Leslie George couldn't slay the dragon of bulimia alone, she sought help, and she was refused. Although she remained in the hospital, the next morning Leslie died. She died of septic shock. Her organs shut down. The medical staff tried to intervene to save her, but it was too late. Anorexia or appendicitis. bulimia or bronchitis, binge eating or broken bones. It is unbelievable that one illness would be given preferential treatment over another, but it happens. So one solution to this high death rate that everyone on the panel has addressed is the federal response to Eating Disorders Act, the F.E.A.S.T Act, which Senator Harkin and Senator Klobuchar and Senator Franken have introduced. This is the first only eating disorders bill, comprehensive eating disorders bill in the history of Congress, so that's more than 200 years. By focusing on research, education, prevention, and treatment, the F.E.A.S.T Act ends up being a beacon of hope, that people will no longer be misunderstood and mistreated due to such ignorance. The F.E.A.S.T Act has a section in it that basically will make sure that doctors and nurses do not need to live behind a memory that Leslie, emergency room doctors, is now living. What a tragic mistake and what a devastating loss for Leslie's parents. And it's unnecessary. So the F.E.A.S.T Act will give our medical professionals better training and tools for treating people with eating disorders, just like they treat patients with leukemia or lupus. We also need education efforts. I already said that. We need more research dollars in order to uncover the best treatment approaches to treating eating disorders. We need better access to care, so those who are suffering from eating disorders have a chance and a fair opportunity to recover. I just love the vision that Laura just outlined for us, that we were able to really talk about recovery as being the norm. And people can and do recover, and it's unnecessary that people are dying. And so the F.E.A.S.T Act has different pieces in the bill that will, in fact, be part of the solution here. So we actually urge members of Congress, you are part of the solution. You can save lives, and 10% is unacceptable. So we actually urge you to review the bill and to add your name, to sign on to the F.E.A.S.T Act today. Don't wait. We've run out of time. So in the Senate, it's S-481. And we have a whole section on research. And the research is basically, that section is designed in such a way that we just have more research dollars. We bring in more experts into the field so they have training. There's some training money in there, so we can bring in more scientists into the pipeline. We can have a better understanding of the death rates. We understand the etiology, and of course, most importantly, good science-based treatment, treatment that works. In the education and prevention section, we have grant programs that would train health professionals. That's what I was alluding to earlier. So doctors and nurses and pediatricians and dentists, etc., all have some training in terms of what are the signs and symptoms and how do I appropriately address this with wisdom. We also have a section in here where people, educators, and those in the school system will be able to identify when someone might be suffering from an eating disorder and how to effectively respond to that, who to refer them to, what are their appropriate resources there. There's also public service announcements. There's a section that is talking about how obesity initiatives really need to have a whole understanding of eating disorders in their efforts so we don't create more problems as we try to address that issue. And then in the treatment section, we have basically it's all about how to have more access to care so that people who are seeking treatment aren't refused simply because they don't have the money or resources to pay. So we look forward to seeing more senators signed on to this bill after coming to this briefing today. I would like to open the floor. We have 10 minutes, which is great. And I'd like to open the floor. Go ahead, Laura.
Actually, there's something that I ask all the parents
look around the room and you can see the pictures that parents are holding up, family members are holding up.
And along with these are grandparents and uncles and aunts and brothers and sisters. And all of these families just represent one small sliver of the effects out there.
Yes.
Hi, I'm Sarah Singleton with Senator Harkin, and I just really have more of a comment than a question. I want to thank Janine so much for your work putting this together today, and F.E.A.S.T and the Eating Disorders Coalition. You guys have done a great job of bringing awareness to this issue. And Janine, thank you so much for the discussion about the F.E.A.S.T Act. Senator Harkin, as she mentioned, is the chief sponsor of the legislation. And if anyone has any questions or wants to co-sponsor or needs any information, feel free to get in touch with me, Sarah Singleton. Because we would love to have more support for the legislation and for all of the families that are here. You're the most powerful advocates we can have in trying to bring attention to this issue. So thank you for attending today, and thank you for your work this afternoon going around and trying to raise awareness of the legislation.
And of course, let's give Sarah and Senator Harkin's office a huge round. This bill. How about questions or comments? Yeah.
Can you explain where the bill is? I know it's been on the table a number of times, but where are the details of the bill?
Sure. The bill has been referred to the committees of jurisdiction. So in the House, that's the Health Bill, and in the Senate, Health Committee, in the House, that's Energy and Commerce Committee. And we currently have 27 co-sponsors in the House and 9 co-sponsors in the Senate. Yeah. So next year, session starts over. For all of you in the audience who know this, forgive me, but we start a whole new session, so we will reintroduce the bill then. Our version of the bill. We'll be reintroducing everything then, and you kind of have to start all over. Yeah. Yes?
So was the bill wasn't brought up to the Senate or for vote?
No. This is a pretty young bill. It takes a while typically to pass bills. I think the Second Parity Act, 12 years to pass. So we just introduced it for the first time in 2009. In the House in 2010 in the Senate. So this is only the second time it was introduced, was this particular session. So the way it typically works is you introduce a bill and then you really have to do a lot of things like this, a lot of legwork and constituents calling and meeting with their members to help them see how important and useful this particular legislation is. So that's where we're at. And I think we've been doing, in some ways, a really good job. And we'll get this passed eventually. Yes?
People have to understand this is not really anorexia nervosa. This is anorexia fetalis. And that's really, the idea that this is some nervous condition that we're going to get rid of easily is just ridiculous. When you see the child just spiral, they're not there anymore. It's not at all understood in our culture, and people just have no clue this idea of choice. And that go eat a cheeseburger, one pediatrician will probably give her a piece of jewelry, and she'll eat a cheeseburger. A pediatrician actually said it. And people need to know this is a fatal disease, and we need to do a whole lot more. And there's a lot of disordered eating in our country, but there's not as much eating disorders, and we're really using that.
Slide 9. Do you want to say anything about that?
No, my main comment is it is very important that we don't mix this up with a lot of things that really don't have the same clinical significance. And I think for exactly some of the reasons you're talking about, some of the stigma associated with it, some of the just the ignorance associated with eating disorders, I think that's why some of that actually does get trivialized, is because, again, I don't think typical dieting, so so I absolutely agree with the point that you're making. And this is something we're hoping to go forward with an initiative. And one of the things that I want to make sure is not in that initiative asking for a specific type of research is disordered eating. Because that thing is defined in 20 different ways. It's purely opportunistic, and half the time doesn't even get to what the crux of the real problem actually is. So, and also, talking about obesity and eating disorder, from a psychiatric point of view, it absolutely isn't. The DSM-5 committee, who's now going to be, changing slightly, making changes with the diagnostic category for the eating disorders, they clear consensus absolutely did not allow that to happen, which was so important. It's not that obesity is not a public health problem, it absolutely is. But these are very, very different, and I think confusing the two is scientifically it makes no sense. And
Is there a question? Yes.
Off the top of your head, what are the senatorial co-sponsors?
Oh, I have a list of that. Are you going to stay for the second part? Okay, we'll talk about that then. So, and actually what I'd like to do, I want to make sure we have a couple of minutes. Is there anybody from congressional offices that have a question or comment? I'm going to leave a little bit of space for that. Anybody? Okay, then we've got time for maybe one more. And who do I pick? There was a woman back here. Go ahead. Right here. In the middle, the one who keeps turning.
Yeah,
Someone else.
I have a question for Dr. Chavez.
Okay, great.
Within NIMH, it's clear from what you're saying that there's a good understanding of the lethal and other aspects of eating disorders, the seriousness and the prevalence. But when you look at the website in terms of research, there's not that much being done, and I'm wondering, do people like you talk to the people who decide where the research dollars are going, or what the priorities are within NIMH, and if you could comment on what direction you think they're going?
very, very good question, because actually, I've seen the numbers. We actually have the numbers where we look at the amount of research funding that goes in to look at specific disorders. And there's no question that for the eating disorders, there really is less research money to say for schizophrenia or for depression. A couple of things, though, that the person has to understand to put this, to put this within a certain context. And I don't think anybody at NIMH is pleased with this. I don't think this is where we think the state of the science needs to be. I think this is absolutely a priority for our institute. And I can honestly say this. I mean, this is something that Congressional actually takes very personal. Every time we have applications coming in, he always wants to find the eating disorders application. What's going on with this? Is this something we can fund? So there's no question it is viewed as a priority. But you have to remember at NIMH, we can't fund applications that we don't receive. And the extramural research community is a very small community. Relative to the number of investigators who study schizophrenia, who study depression, though it's a very, very small extramural research community. And the other thing we can't, so we receive, so if you look at the, let's say the differences between depression and eating disorders, the amount of NIMH funding that goes into it, it really does reflect the number of applications that we also receive. And so, and we also, one of the things that we can't do is we can't fund bad science. Just because somebody submits an application, it goes through a peer review process. People like me don't make a decision whether it gets funded or not. It depends on the scientific expertise of their peers who give it a certain priority score based on the scientific merit of that application. If it reached, so if it is viewed as being meritorious, if it's something that could actually, important could come out of it, that application would actually, would be funded. But if it's not good science, and they don't think it's good science, it gets a very bad score. The last thing that we want to do is be putting money for people asking questions that aren't good questions, are going to be moving the field forward. First of all, it just puts out more information and there's more noise than any signal. The second is that those people could be doing some very, very important research. They get funded for doing bad research. They can spend 4 or 5 years doing that bad research. We need them doing the good research. Again, it's a very small community. There's some very good investigators, I'm sure, the Cindy Dulles, the Walter Kays, those people. There's some very, very good people, but we do need more of them. And I know one of the jobs I have at NIMH is looking at people who are the young investigators, people in medical school, people hopefully who are going to research, or people in graduate schools, people who are doing postdocs, assistant professors. And again, it's very frustrating because we don't see that many of the junior people coming up. And we're getting ready to fund a grant from Columbia focusing specifically on eating disorders. We're very pleased with that, but we don't think we have enough training grants, but part of that reflects just the small number of investigators out there. So I completely agree with you. I think we're equally as frustrated, but I don't really know more I can say.
Thank you so much. That there is a piece in the FREAD Act that would actually provide funding for new investigators. So that's a positive component of it. Thank you, everyone. That is the end of our time. I want to thank the speakers again for their participation. So let's give them so those of you who are going back, let's see, how's that working? Laura, do you need